After all, there is nothing as interesting as people, and one can never study them enough. Vincent van Gogh. DSW 2310, Dual Diagnosis, Treatment and Assessment, Bipolar and Related Disorders. Bipolar consists of alternating episodes of depression and mania. Mania is a state of elevated mood as well as increased energy levels. Person feels euphoric, excited, expansive, wild flights of fancy. Energy levels are extreme. Their mood is like a high. They are overambitious. Person seems like they are lots of fun, life of the party, infectious, etc. Mania. Hyperactivity and restlessness are common. Diminished need for sleep. The high energy levels result in not wanting to sleep. Person may commit to unrealistic and ambitious projects or believe that certain fantasies are true. Person can become reckless, sexual promiscuity, giving away possessions, making unwise investments, etc. Completes many tasks simultaneously. Mania. Person is loud, speaks rapidly, and speech can be excessively dramatic and theatrical. Speech appears pressured and can be difficult to interpret. If in an irritated mood, speech may consist of complaints or tirades. Angry at people who want to help, may believe that certain people have done them wrong. Person's thoughts race at a very fast pace. Thoughts jump from topic to topic, making it difficult to express themselves, which can be distressing and causing the person to feel out of control. Mania affects all elements of a person's life: moods, thinking, speech, actions, relationships, and sleeping. Symptoms of manic episodes in people with developmental disabilities. Duration of at least 1 week. A. Elevated mood, boisterous, playfulness, constant excitement, higher levels of laughter, giggling, smiling, invading personal space, teasing, difficult to redirect, elation not related to the situation, or irritability, self-injurious behavior, increased goal-directed activity or energy. B. In addition to A, there is 3 of the following, if elevated mood, or 4 if irritable mood: inflated self-esteem or grandiosity, decreased sleep, more talkative or pressure to talk, preservations, repetitive questioning, racing thoughts, distractibility, agitation, hedonism, sexually inappropriate behavior, no limits or boundaries. C. Episode causes disruption in daily functioning, such as hospitalization. Reporting. Crucial to report. Entire pattern of symptoms. Symptom domains of bipolar disorder: manic mood and behavior, euphoria, grandiosity, pressured speech, impulsivity, excessive libido, recklessness, social intrusiveness, diminished need for sleep. Dysphoric or negative mood and behavior, depression, anxiety, irritability, hostility, violence or suicide, all leading to bipolar disorder. Psychotic symptoms include delusions, hallucinations, formal thought disorder. Cognitive symptoms include racing thoughts, distractibility, disorganization, inattentiveness. This all assists clinicians in making the correct diagnosis. Hypomanic episodes. Same behavioral symptoms as manic episodes, plus shorter duration, 4 days instead of 1 week or more. Changes in mood and functioning not severe enough to cause serious disruption in functioning or to result in hospitalization. No psychosis. If psychosis is present, a manic episode is occurring. Cyclothymic disorder, rapid cycling. Cyclothymes are individuals who move quickly from state to state with moods being fairly short, also known as rapid cyclers. Moods last only days or hours at a time. Associated with bipolar disorders. Have at least 4 distinct mood episodes within a 1-year period. Rapid cycling linked to poorer treatment outcomes. 70 to 90% of rapid cyclers are women. Prevalent in persons with developmental disability. Have higher rates of thyroid problems. Bipolar I disorder. Periods of mania alternating with periods of depression. Hypomania may also occur. Persons with developmental disabilities have been diagnosed with bipolar I disorder. Bipolar II disorder. Alternating periods of hypomania and major depressive disorder. Mania is less extreme than bipolar I. Females are overrepresented in bipolar II disorder. Rarely studied in people with developmental disabilities. Suicide and bipolar disorder. Bipolar I is associated with an increased risk of suicide. 15 times higher than the general population. 25% of all completed suicides are committed by people with bipolar disorder. Suicide attempts of people with bipolar I are more lethal than those who have been diagnosed with depression. Bipolar II has a high risk of suicide. A third of people report having attempted suicide. Bipolar disorders and dual diagnosis. Is difficult to diagnose. Symptoms of mania also characteristic of developmental disabilities. The key is to document and record changes in behavior, atypical or worsening. Need to investigate person's life circumstances. Cycles may relate to seasonal changes. Summertime staff may take holidays, going home for Christmas. Prevalence rate assumed to be between 0.8 to 2.6%. Decreased cognitive function increases likelihood of bipolar depression. Persons with Down syndromes rarely have mania. Persons with Fragile X syndrome have an increased risk of developing bipolar disorders. Causes of bipolar disorders. Diseases which produce mania, epilepsy, hyperthyroidism, multiple sclerosis. Medication that can produce mania, antidepressants, marijuana, Ritalin, steroids, etc. Antidepressant-induced mania is a well-documented phenomenon and is known to occur in persons with developmental disabilities. We must ensure that the diagnostic process for a mood disorder in someone with a developmental disability is very thorough. Causes of bipolar. Genetics. People with a first-degree relative who has bipolar I disorder are 10 times more likely to develop bipolar disorder. Heredity plays a greater or more significant role in bipolar disorder than depression. Neurotransmitter abnormalities. Dopamine dysfunction, problems with self-control. Psychological factors. Psychoanalytic perspective states that manic states are defenses against fear of object loss, intense fixations on love objects, insatiable narcissistic, self-absorbed needs, and impaired family dynamics. Social factors. More common in high-income countries. Separated, divorced, or widowed individuals have higher rates than people who are married or who have never been married. Treatment of mania. First, rule out any possible medical or medication causes of mania. Prodrome. Period 1 to 2 weeks with abnormal changes in mood and cognitions which precede a depressive or bipolar episode. Therapy. When you can predict that someone is entering a manic episode, it allows you to be prepared to support the person. Medications. Lithium highly effective. Anticonvulsants. Importance of charting defining stages. Mania. 10. Total loss of judgment, exorbitant spending, religious delusions and hallucinations. 9. Lost touch with reality, incoherent, no sleep, paranoid and vindictive, reckless behavior. Hypomania. 8. Inflated self-esteem, rapid thoughts and speech, counterproductive simultaneous tasks. 7. Very productive, everything to excess, phone calls, writing, smoking, tea. Charming and talkative. balanced mood. 6. Self-esteem good, optimistic, sociable and articulate, good decisions and getting work done. 5. Mood imbalance, no symptoms of depression or mania. Life is going well and the outlook is good. 4. Slight withdrawal from social situations, concentration less than usual, slight agitation. Mild to moderate depression. 3. Feelings of panic and anxiety, concentration difficult and memory poor, some comfort in routine. 2. Slow thinking, no appetite, need to be alone, sleep excessive or difficult, everything a struggle. Severe depression. 1. Feelings of hopelessness and guilt, thoughts of suicide, little movement, impossible to do anything. 0. Endless suicidal thoughts, no way out, no movement, everything is bleak and it will always be like this. Importance of charting. Use consistent definition and criteria for charting. Obtain historical data. Chart for a lengthy period of time. Sample mood chart. Bipolar Diary, page 1. Bipolar Diary, page 2. Sleep chart. Sample of outlining baseline patterns of functioning. Beams, behavior, energy, appetite, mood, sleep. Sample of outlining baseline patterns of functioning. Beams. B. Behaviors. Document any noticeable changes in behavior. E. Energy. Document changes in energy levels. For example, walking slower or faster, cannot sit still, moves more slowly, etc. A. Appetite. Document if refuses to eat, eats more, throws plate on floor, eats non-food items, pica, hides food, etc. M. Mood. Document if cries a lot, looks sad all the time, more irritable, frequent bouts of giddiness or silliness, doesn't show range of emotions, looks worried or anxious, etc. S. Sleep. Document patterns, sleeps a lot, sleeps less, cannot stay awake, wakes up screaming, has difficulty falling asleep, etc. Support. Protect. Be supportive. Don't punish. Maintain normal routines. Reduce irritations. Acknowledge anger and deal with it appropriately. Reduce stimulation. Reduce use of stimulants. Do not get caught up in euphoric or unrealistic expectations. Have brief conversations. Avoid being authoritative. Encourage sleeping. Limit ability to spend money.